project is to improve the treatment of breast cancer brain metastasis using nanomedicine. And brain metastasis has very poor prognosis, and it's actually much common than we expected. There's around 25% of cancer patients that would eventually get brain metastasis. Autopsy studies have shown that there's actually more than 25% of patients with brain metastasis. And these patients, they experience very severe morbidities like headaches, loss of balance, and these headaches are usually due to the growing tumors that's in their head because it creates so much pressure. And because the brain is such an important organ, the patients usually has very short survival if untreated, usually less than a year. Brain mets are usually diagnosed with MRI, with contrast enhanced. So without contrast enhanced, we can see that there's a bit of shade in the tumor region. And with contrast agents, the contrast accumulates within the tumor and actually lights it up. Unfortunately, these brain mets are often detected late because they don't show symptoms when they are small. They only start showing symptoms when they are larger. So these patients are often detected late. The main treatments aim to prolong survival and mostly palliative to relieve headaches. And the standard treatments are radiotherapy using whole brain radiation or gamma light, which delivers a focused beam to the brain. And surgery is usually used to debulk the tumor to relieve the pressure in the brain. This is only applicable if there's only one brain met. If it's very diffuse, there's multiple mets, it's very hard to use surgery. Chemotherapy are used for patients with brain mets, but also mets that's elsewhere in the body. Very often, the treatment outcomes is that the brain mets usually come back. It's quite frequent, and because of the adverse side effects, there's a large numbers of patients that are not suitable for any of these treatments, except steroids to relieve the symptoms. So there's actually very limited options and a lack of effective therapies for this group of patients. So chemotherapy is actually quite good because one thing is non-invasive, and second is effective against cancers. It can kill cancer that's difficult to remove surgically, such as diffuse mets, and it can reach multiple niches in the body, like systemic mets. So in the brain mets microenvironment could be quite heterogeneous in terms of the vasculature. And with the small mets, they usually lie quite close to the blood vessels where they're still protected by an intact blood-brain barrier. So drugs in the blood has difficulty reaching them. But when they grow bigger, they actually disrupt the blood vessels, which supplies them with nutrients, and they are also actually more susceptible to drugs. But there's still some factors limiting the use of chemo brain mets. One thing is that the blood dynamics, the perfusions around the brain is quite uneven. So it's quite inconsistent, and the drug uptake to these tumors is quite patchy. And because of the constant clearance of drug by the body, it's very hard to concentrate all the drug to the brain. So the concentrations of drug in the brain is quite heterogeneous as well. And there's chemotherapy, there's adverse toxicity because it's also harmful to normal proliferative cells. It's a shotgun approach. We don't know which cells it will actually affect. And lastly, there's actually growth factors in the brain which cancer cells take advantage of to drive their own survival signaling. So these are the factors that limits chemotherapy against brain mets. But I think that nanomedicine would be a solution to this. So nanomedicine is the application of nanoparticles to treat diseases, and nanoparticles are usually defined by how small they are. They're extremely small, about 4 to 200 nanometers. So in comparison, the thickness of a piece of paper is 100,000 nanometers. They are commonly used to deliver drugs in patients. There's multiple types of nanoparticles. The type of nanoparticles that I'm using in my project is known as a hyperbranched polymer, also known as HBPs. So they look like they have multiple branches. It's very easy to produce in terms of the chemistry. They are stable, they do not degrade easily in the body, they are biocompatible, and they can be multifunctional because it really depends on what molecules you attach to the branches. So in my project, I'm attaching a targeting, diagnostic, and a therapeutic molecule to the branch. This is how the hyperbranched polymer looks like. It's comprised of a polyethylene glycol backbone. So PEG is good because it actually reduces and slows down the clearance of the drug. So it prolongs circulation. And this is quite desirable in terms of anti-cancer drug because by circulating longer in the body, it encounters cancer cells more frequently, so it increases the drug accumulation within tumors. The polymer is developed by our collaborators at CAI. So on this polymer, we attach an antibody fragment known as a BSAP. It is 4 times smaller the size of a typical antibody. So the purpose is for targeting, identifying cancer cells. And next, we have a therapeutic drug, a chemo drug known as doxorubicin. It's attached to the polymer with an acid-sensitive linker. So in an acidic microenvironment, it actually loosens up it and releases the payload. And then we have a fluorescent probe attached to the nanoparticles, so we can actually monitor, like real-time monitor, where is the drug, where is the biodistribution, and potentially it can be used to detect micrometastasis, early detection, and used for diagnostics. And over here is the example of a picture of a mouse with accumulation of this HBP in the tumor region. So this is the mechanism of action of HBP. So the polymer circulates the body, and when it encounters a tumor, it actually accumulates in the tumor. And when it actually finds the cancer cells, it actually targets the receptor, and this causes receptor internalization along with the HBP. And within these endosomes, where the cellular pH is very low, it's acidic, it triggers the release of doxorubicin, which then inhibits mitosis and triggers cell death. So this is how it actually looks like. So within the brain, where there's disrupted blood-brain barrier, actually crosses and affects established brain mets. So my targets are HER2 and HER3 receptors. So with our previous work found that HER2 and HER3 are expressed in a subset of brain mets, and not just breast cancers, but other cancers as well. And HER2 receptors is always in an active conformation, whereas HER3 requires activation by its ligand, neuregulin, before it can do anything. And unfortunately, neuregulin is a growth factor that's very abundant in the brain. When both these receptors are active, it dimerizes, and the downstream pathway drives cell survival and proliferations. So the clinical problem is that the downstream pathway actually helps the tumor to become resistant to treatment, so that it's harder to kill. And so my targeting of both HER2 and HER3, actually there's 2 aims. One is to help the HBP to identify cancer cell. Secondly, by blocking HER2 and HER3 signaling, we can actually enhance the treatment efficacy. So the aims of my project is to first develop a brain met mouse model to optimize the technique and to characterize the model. Second is to characterize a HER2 and HER3 targeting HBP using in vitro assays to investigate the specificity, drug release mechanism, and the cytotoxicity on cancer cells. And the second part is to look at efficacy, biodistribution, and toxicity using the brain met mouse model. So what I found is that the BSAPs, which is the antibody fragment against HER2 and HER3, they are specific. So what I did was an ELISA assay, And by putting the HER2 biceps against HER2 proteins, we can see that there's actually a signal being picked up. The same is for HER3 biceps. But when I reverse the targeting, like I try to put HER2 bicep against HER3, there's not much signal, and the value actually lies below this curve. And I also put the biceps on HER2 and HER3 expressing cell lines. And we can see that if it expresses HER2 and HER3, it actually leads up the cell. Whereas when I try to put it on non-expressing cell lines, where there's no HER2 and HER3, there's no signals. Then I also try to put on cells that express HER2 and HER3, and we can see that over a period of time, the targeted HPP was internalized into the cell compared to untargeted polymer. There's actually slower accumulation. This is because the cancer cell still actively sample its microenvironment. So this accumulation is due to the active sampling of its microenvironment. This is another assay that looks at the internalization. We can see that at earlier time points, it actually coats the cell membrane. And after 2 hours, it starts to move into the cytoplasm. Then I also look at the drug release. So I have different beakers that has a different pH of PBS. And when I drop the nanoparticles into this environment, I start to sample for doxorubicin, and we can see that with the more acidic microenvironment, like pH 5.5, there's actually a higher release of doxorubicin over time. So the pH I uses are 5.5, 6.8, and 7.4. The physiological relevance is that at pH 5.5 actually resemble what is like in a lead endosome or lysosome. And 6.8 is actually quite closely resemble the tumor microenvironment and early endosomes. In other parts of the body, like our blood plasma, in healthy tissues, usually at 7.4. And after a period of 48 hours, I actually found that at acidic pH, the release is actually almost twofold than that of normal tissues. And in my cytotoxic assay, so I've used untargeted HPP doxorubicin. So without targeting component, the HPP dox is actually less cytotoxic than free doxorubicin. With free doxorubicin, it actually reduces the cancer cell viability by almost 50%. But the HPP itself, the polymer itself, without the dox component, it doesn't really kill the cancer cell at all. And even with a dox component, it's not cytotoxic at high doses. So what this means is without the targeting component on the nanoparticles, it has less toxicity against patients, against healthy tissues. So this is good because it has a fewer side effect compared to free dox. So by attaching the HER2 and HER3 targeting antibody on the nanoparticle, you can see that it actually is able to reduce the cell viability of cancer cells by close to 50%. So this is even without having a doxorubicin payload. So this actually shows that by targeting these two receptors, there's actually some cytotoxic effect. And I've tried two types of combination. One is to have polymers with HER2 and HER3 targeting. And the other combination is to put both HER2 and HER3 targeting antibodies on one nanoparticles. So these two combinations are as effective. And then by attaching the payload, which is the doxorubicin, we can see that the cell viability on cancer cells falls way below 50%. So having a payload is actually most more cytotoxic and more effective. And the combinations treatments, regardless of whether we use two different types of targeting polymers or having both HER2 and HER3 targeting on the same polymer, they are as effective, they are similar toxic. So what's next is to look at the cell signaling pathway, like using Western blots to see if targeting of the receptors leads to a quenching of their downstream signaling pathway. And I'm also going to use flow cytometry to see if the nanoparticles can disrupt the cell cycle. So next I'm going to talk about my brain met mouse model. This brain met mouse model is created by injecting cancer cells into the carotid artery, which lies around the neck here. So the reason is because the carotid artery supplies blood to the brain. So by injecting cancer cells into the carotid artery, the brain will be the first organ that will be seated with cancer cells. And this technique actually simulates the metastatic process. And what we found is that it produces both micro, which is very small, and also very large tumors in the brain. And it does so within a relatively short time frame, like 2 to 3 weeks. And it generated quite limited extracranial mets, which is tumor that's elsewhere in the body. So this model actually creates a brain-only metastasis. So this is the common carotid artery. There's two branches here. One is the internal carotid, which leads to the brain, and the other is the external carotid artery, which leads to the cheek. So the first step is to identify the branch. Next is to fix a ligature here and to ligate the external before injecting. This way, most of the cancer cell would lead only into the internal carotid artery. So these are images of my practice. And you can see that if once the injection is successful, it actually seeds, the injection actually leads to the brain, turns the brain green here. And my cancer model is the cell line BT474. It's a breast cancer cell line that expresses HER2 and HER2, which is my targets. And this is verified by immunofluorescence that show HER2 and HER3 expresses. The cell line is also tagged with luciferase, which is a bioluminescence marker. This is so after we inject into the mice, we can actually use in vivo imaging to track the brain met's development. The amount of cancer cells I injected is 250,000 in 100 microliters. And after characterizing my model with 18 mice, I found that 50% did not develop brain mets because there's complications or there's just some reason that the cancer cell actually die inside the mice and there's just no tumor developed. I'm using an immunodeficient strain known as not-skits, and the average endpoint is around 2 months. That's when they start showing weight loss, severe weight loss, ruffled fur, and they look hunched. And on autopsy, I did not see any extracranial mets. With the recent cohort, the success rate has gone up, maybe because I'm getting better at the surgeries. And the success rate is now 90 to 95% because I have around 19 out of 20 mice still alive after the surgeries. This is how the bioluminescence imaging looks like. We have week 1, 2, and 3 up to 8. And the images shows that at week 8, we have strong signals coming from just the head. This is because the tumors are growing and the signals get brighter over time. So this helps us to determine when should we start treating the mice. So these are early time points, and this would be the middle frame where the cancer cell starts to get used to the brain, start to proliferate and form micromets. And we are usually treating around this time. And at the end of the experiment, I perform a necropsy. These will all be processed histologically and then sectioned to see if there's cancer cells in these organs. but sometimes we can even see the tumor attached to the brain. So this 10 piece of tissue that's underneath the brain is the tumor. And what I usually do is to slice them up into pieces and fix them at level 5 histo suite. And then what I do next is to perform a histochemistry against the HER2. And with mice that develop tumor, we can see the tumor quite obvious. It's quite obvious. And this is how it looks like. There's a combination of both very small mets, and there's also very large established mets where there's also regions of necrosis. So this actually resembles what's in the patients in the clinic. And so what you're looking here is a H&E image of the brain met. And here is a very large established met. So this will be a region where there will be much more disruption in terms of the blood vasculature. And then there's also a small mets here where the blood vessels would probably be less disrupted. And we also perform MRI scans of these brain mets to assess tumor volume. This is done at CAI, and this is just how the MRI machine looks like. It's actually relatively smaller than the MRI machines in the hospital. So this is the size of a mouse. So the mouse will be actually pushed into the MRI machine where it gets scanned. This is how the MRI images look like. There's transverse view, sagittarial view, and coronal view. So at week 1, we don't really see much tumor, and on the bioluminescence, we don't see a signal as well. Week 5 and 8 onwards, we start to see tumor developing, and in the MRI, we can actually see white spots, which is actually the tumor. So we actually compare the endpoint with histology. You can see almost half of the brain is filled with tumor in this mouse here. So what's next in my project is to look at in vivo treatment. So I'll be treating these mice with free doxorubicin and with just the HBV polymer and dox, and then also the targeted HBP with dox to see which of the treatment will be most effective in prolonging the survival of these mice. Then at the end point, I will be also looking at biodistribution using histology to see where is the dox. And then we will use MRI and also PET-MR to look at how permeable is this brain mets, and also to look at off-target toxicity by doing histology of the organs to see if there's cardiac toxicity in the hearts or other organs. So I'd like to thank my collaborators. This work is a collaboration between our lab with CAI and also AIBN, and also the guys at CSIRO. Thank you.
Great stuff. Thank you very much, Malcolm. I should have mentioned at the beginning, Malcolm has a background from a diagnostic histology lab, and so I'm sure that plays a big role in some of these amazingly difficult techniques that he's shown today, including the intracarotid injection. The carotid artery of a mouse is absolutely tiny. You know, also some of those beautiful IHC images that you showed, Malcolm. I'm sure your experience in the diagnostic setting has been an asset. Does anybody have any questions for Malcolm? I think it's probably a bit mean if I lead the questioning. No questions? Surely someone.
I do.
Thank you. Thank you.
So Malcolm, you know how your engraftment efficiency has increased in the latest cohort?
Yep.
Are you delivering the same amount of cells, or you're just, why do you think it has gone up from 50 to 95%?
So, so everything else has essentially remained the same. So I think the improvement is due to more practice, because now I'm avoiding the essential components around the neck. With carotid artery injection, there's a lot of fiddling around the neck organs, like the neck muscles, and there's a vagus nerve which runs parallel to the carotid artery.
Yeah.
So I'm just trying to avoid these organs and these tissues, so that it causes less morbidity to the mice. So I think they actually get back better after surgery.
And you know how you had massive tumors, like almost half of the brain was like tumor?
Yeah.
Have you done like a dilution of like different cell numbers, and maybe because you're doing so there's two questions there.
Yep.
Does that change, or the days, you know, that the mice take to develop, you know, the massive tumors, does it change if you reduce the amount of cells, or it doesn't really matter?
So with our very early characterization study of this model, I've actually tried both 100,000 cells,
Yeah,
and also 250,000 cells. And what we found is that regardless of this different concentration, the mice still develop the tumor in a relatively similar time point, which is around week 4 and 5.
and why do you think so?
It doesn't really affect them much, because the carotid artery actually sits directly to the brain, regardless of 100 or 250,000. A brain met that one that's developing would just develop. It doesn't really matter how much of cells you see. It doesn't change the speed of progression.
Yeah, so so are you saying that few of the tumors that get in the brain and survive, once they're there, it doesn't matter like how many you deliver, only a few of the clones would be thriving in that environment?
Yeah, I mean, even with 100,000 cells, there's still a lot of cancer cells relatively to what is going on in the actual patient, where there will be definitely much lesser cancer cell that
so with, you know how you're starting the treatment in the, is it the mid where was that?
Yeah, it's around week 4.
So have you done histology on that? How big do the tumors look at that point? The proliferative point. Have you
we haven't really done any histology for week 4, because we just decided to let the disease progress and see what kinds of tumor we get at the end point.
Okay, so you've decided that the treatment window at that because
that's when we can start tracking them on bioluminescence imaging.
So you were relying on luciferase signal, and you're like, yeah, we can start seeing it. We're going to start treating it now.
That's correct.
Okay.